Professor Braun, Dr. Ringden, and also Cardinal Turkson for this invitation to this really beautiful building and this fantastic venue. I am a clinical hematologist, and I was the director of a cancer center for 10 years, so that's what I bring to this table. Now, is there a gap? Obvious, there is a gap. What are the reasons for this gap? I believe the most important is the unequal distribution of resources. Secondly, education and social factors, and we had speakers who brought that out very clearly this morning. The third is access, and the fourth is the gap between infrastructure and demand. What is the gap? Gap is in the number of cancer centers which can provide care, in the available diagnostics, in radiation therapy, in drugs that are needed to treat cancer, in palliative care and pain relief, and in prevention. So these are the gaps that we identify, and that's evident to all of us. Now, this is India's Union Budget 2023, presented 3 weeks ago by our finance minister. We are now the 5th largest economy in the world, 3 trillion rupees. And you can see here the sad fact that only 2.2% of the budget is allocated for health, and that is $4.8 billion. She called it a pro-poor budget. I don't think pro-poor, and therefore I am aligning with my previous speaker in criticizing the political establishment that it is not pro-poor. Why is it not pro-poor? It's not pro-poor because we've cut the taxation on the very rich in our country. Now, this is an Oxfam report on the survival of the richest, the India story. Poor are suffering, the rich are getting richer, and the wealth concentration among the richest is increasing. In 2021, India increased its number of billionaires from 100 to 160. The top 1% of Indians own 40.6% of the total wealth of India. Now, this graphic is again from the Oxfam report, and it shows here that a 3% tax on the 160 billionaires would provide $25 billion, which will take care of India's health budget for 5 years. So the biggest problem we face is not that we don't have the resources. We have the resources, but it is not properly distributed, and there's a concentration of wealth, and this has to be addressed if we are to improve the quality of care for patients with cancer in our country. Now, this slide is a very, very familiar slide, and what we need is equity, not equality, and it can happen really well if there is liberation. Now, this is a paper I wrote in 1995, and it was entitled Childhood Acute Lymphatic Leukemia, a Treatment Approach in a 3-Tier Society. This was published in the Journal of Pediatric Oncology. And in this, I highlighted that our population is of 3 types. Population which is very poor, 70%, 28% which is the middle class, which can afford to have reasonably good treatment, and profile 3, which can have any treatment available anywhere in the world, and that's 2% of our population. Now, this is an example of how we would treat these 3 tiers of our population for a simple disease like Hodgkin's lymphoma, stage 4. Every person is entitled to an accurate diagnosis, and that costs only $300, including histopathology, immunohistochemistry, everything. You add on a PET scan and it'll go up to $600. It's not a big difference. So I believe that it's possible to get a good, accurate diagnosis and staging for $600. That's all you need. Now, with regard to treatment, in the government sector and for the 70% of our population, it would be ABVD, and we can afford to give ABVD. The total cost of 6 cycles is only $500. If you relapse, then it is only profile 1 and maybe half of profile 2, which can have targeted therapy with brentuximab, nivolumab, autologous stem cell transplant, all of that, which should go up to beyond $10,000. Now, is this cafeteria approach correct? It is not ethical. But till such time as we are able to equalize, I believe we keep the gold standard in front of us, and while we aim for that gold standard, we do the best that's possible. Things are changing in India. In West Bengal, where I worked for the last 12 years, the government provides as much as $5,000. That's a lot of money in India. $5,000 per family per year for healthcare. So it is changing, and most states in our country now are providing this sort of money to reduce the out-of-pocket expenditure which Indians have to spend if they do become sick. This is Globocan data for India. I won't belabor the statistics. With a population of 1.3 billion, we actually have 1.3 million new cases of cancer per year and 851,000 deaths. Now, in terms of prevalence and incidence, India is green there. North America is deep blue. You can see that there's a tenfold reduction in the incidence of cancer. And I don't think this is because we're not diagnosed, right? This is for females. Again, you can see much less than the Western world. The commonest cancers in India in men are oral cancer, stomach, lung, liver, esophagus. In women, it was cervix. Now it is no longer cervix, it is breast, then come the others. And in children, as in the Western world, it's leukemia, CNS tumors, solid tumors, and lymphomas. These are the common cancers in children. What are the future trends for cancer in India? Our population pyramid is changing from one which was like this, gradually towards a Western type of population pyramid. And because of that, the proportion of patients with cancer that we're going to see is going to increase. And the prediction for 2025, which is 2 years around, is 1.5 million new cases per year. And governments are going to spend only a limited amount of money, and the out-of-pocket expenditure will be about $3 billion for Indians for cancer treatment. Now, comprehensive cancer care centers was the model for India, and every state was supposed to have a regional cancer center which had all of the modalities required to treat cancer integrated in one, and the private sector has complemented this. In the last 12 years, I set up this cancer center in Kolkata with money provided by the Tata Trust. The total program was 800 crores. That's $100 million of charity to set up a world-class cancer institute. A patient who comes with APL in 48 hours can have a 15-17 fish translocation available. We have all the modalities for radiotherapy. We have next-gen sequencing available. And that's the hospital in beautiful ambience. Most importantly, we have a place where poor people can come and stay. You pay $10 a day. Sorry, not $10, $2 a day to stay in this building while you have your cancer treatment if you're coming from a village in West Bengal. Now, this is the traditional pathway a patient has to go through for cancer care, from initial diagnosis to finally reaching the regional cancer center. So there's a big debate in India now whether the model of comprehensive cancer centers or putting the services where the patients are in rural India would be the way to go. I believe that you need both, and you need to have certain levels of care at the primary centers in the rural India, but you definitely need the comprehensive cancer centers. And this is the model that is being followed. The Tatars have decided to take over cancer care of one state in India, that's Assam, and you can see the human resource crunch which we need to develop if we are to provide adequate cancer care. There's a big shortfall in the number of trained people and the number available, despite having a 1.3 billion population. I have a nurse attrition rate of 25% per year. Many of them, of course, are going to the Western world, but there is a shortfall. Cancer care in India, what are the strengths? With regard to radiotherapy, this is India on the map, which was shown to us by a colleague from I forget. India produces its own cobalt 60, and we have a cobalt 60 unit, which is the one you see on the top left-hand side. And we've just recently produced an FDA-approved linear accelerator, but my own radiotherapy colleagues are not satisfied with the collimators and the beam that is being produced. There is a shortfall of about 1,200 units, megavoltage units required for the country. But I must say that we do have a reasonably good care in our tertiary centers in terms of radiotherapy, in terms of physicists that are required for running the program. I'm very happy that India has a good molecular diagnostics available. This is MedGenome, which is in Bangalore, which within 1 week will give you next-gen sequencing. They have PacBios. They are the largest sequencing center in India. And the market for next-gen sequencing is about $900 million. And you can see in this comparative slide that a BRCA mutation screen in India can be done for $300, whereas it's $2,000 in the US. A comprehensive next-gen sequencing of 500 genes can be done at 1/5 the cost of what is done in the US. One of the biggest strengths of India is its pharmaceutical industry, and we are able to produce drugs at a fraction of the cost. Imatinib for CML costs $16 a month, whereas it's $200 in the United States for 1 month. The drugs of the future. You've been given beautiful exposition of what are the drugs for the future. I believe targeting pathways and monoclonals, both which are plain, which are conjugated, and BiTEs are going to be the way we target antigens. And I'm sad that India doesn't have a good monoclonal program for developing the therapeutic monoclonals that are going to be the future. And we have to pay a huge amount of money for any new molecule that comes up. And that is really a question of justice versus IPR. Blinatumomab is a fantastic drug for relapsed acute leukemia. $178,000 is the price tag, right? Hardly, only this 2% could afford blinatumomab. So really speaking, how much should pharma make or individuals make out of a new innovative cancer drug that can make a huge difference to the lives of many people? And I believe that's one of the things the Academy of the Pontiff should address, this inequity in terms of pricing of new molecules, which are hugely beneficial. Should India have a bone marrow transplant program? I believe it should. Why? We can do a transplant at 1/10 the cost of doing it in the United States, and India now does 2,500, much lower than our population has, but with results which are pretty good. Cancer screening and prevention, there are 272 women in the age group which requires screening for cervical cancer. We don't yet have a universal HPV program. which should be started. There's been only a 3 to 4% reduction in tobacco consumption in the last 7 years, despite the preventive programs that we have. Palliative care, I'm very proud to tell you that Kerala, the state which I come from, has 60 units covering a population of 12 million of community-owned palliative care centers, which is the way for India to go. Our morphine usage is totally inadequate. In Kerala, the calculation is 2,000 milligrams per cancer death as compared to 24,000 in Italy. In conclusion, are we closing the gap? The answer is yes, but not fast enough. How do we do that? We address this problem of unequal distribution of resources. We need to improve on education and social factors. That is happening with the internet. We need to improve access, and I'm glad that in terms of radiotherapy, diagnosis, and other facilities, India is doing something, but definitely not enough for the population we need to serve. Thank you very much.